As we come back, hopefully you had a good break, however you chose to spend it. And we're serious about staying and being on time. So it is just about 1 o'clock, 1:01 actually. And we want to continue with economic justice for an inclusive recovery. If you're joining us this afternoon, my name is Jerome Underwood, the proud president and CEO of Action for a Better Community. So thank you, all of you, for spending this time with us. Those of you who were on this morning, it was extremely engaging, and judging by the questions that you placed to the panelists, we have some follow-up to do with them and with you. So stay tuned for that. This afternoon will be no less engaging. I guarantee you that, as we'll be looking at the issue of maternal justice. But before I do that, before we get to that, rather, just want to take the time again and to just thank our sponsors. Our presenting sponsor being M&T Bank. We have Key Bank. We have also ESL. We have Excellus Blue Cross Blue Shield, and so many others, as you see on the slides. We have sponsors who have done some in-kind work for us. WXXI, big shout out to WXXI and the Evan Dawson show, and many others, numerous to mention. And we will hear, as a matter of fact, we will have those slides running again when we're finished with this panel, and we'll certainly do that next week. But also, all of the sponsor information is available at abcinfo.org. Again, at abcinfo.org. And for those of you who saw the ABC commercial it's about the neighborhood, just know that that's a little sneak preview. We slipped in there today, but it's some very important work that's going to be happening in 2022 that some of you know about, and it's what we call our community needs assessment. And we're really going to be doing that in the neighborhood. Many of you who are on this call and those that you know will certainly we're going to put microphones, so to speak, in your hands so that you can talk to your neighbors rather than have someone not from your neighborhood come to do your needs assessment. So stay tuned for that. That's going to be a major push for us this year, ABC, in listening to what's going on in our community and then designing programming and services around that. While at the same time, we know that the programs and services that not only we, but our colleagues in human services, such as the interrupters over at the Urban League, such as Ibero, such as the YWCA, such as Jordan Health, we know that all the programming that we have by itself will not remove the scourge of systemic, structural, and interpersonal racism. So this conference is our advocacy, where we intend to, like we say, move the earth beneath which racism firmly stands. So this advocacy piece for us is extremely important. And this afternoon, we continue that advocacy, and I'm so pleased to introduce to you our honorary co-chair of this conference, Dr. Gina Kyler. Now, I got to say just a couple things, because many people know Dr. Kyler, as, this board certified doctor, this author, this educator. But I just know her as a bad sister. She's a bad lady, and she's extremely committed to justice. And I'm going to yield to her in a second, as the honorary co-chair, and then she can make some remarks in that regard. And then I will go silent, and she will also be moderating our panel this afternoon based on maternal justice. So Dr. Kyler, welcome, and you take it away.
Well, good afternoon. As Mr. Underwood stated, I am Dr. Gina Kyler, Vice President of Health Equity and Community Investments at Excellus Blue Cross Blue Shield. Excellus is proud to be an inclusive recovery sponsor for this conference. Excellus Blue Cross Blue Shield's mission is to help people in our communities live healthier and more secure lives through access to high quality, affordable health care. Community engagement and supporting programs and conferences such as this are key to our mission to improve access to care, advance specific health outcomes, and support organizations in our community that share our mission. We have the opportunity to use our data, resources, and relationships to stand against structural racism and drive action that reduces health disparities and ensures all our members have what is needed to achieve their full potential. It is a pleasure and an honor to gather together virtually today with all of you to have real conversations about real problems and collaborate to create real solutions. At Excellis, we believe we have a duty to lead by example and inspire positive change within our company, our industry, and broadly in the communities we serve. I believe that this responsibility is shared by all people at all levels of society. Through collaboration, data, and data-driven dialogue, we can create actionable solutions to achieve better outcomes. In addition, with data and data-driven solutions, we can create meaningful metrics to help assess the work that is being done and ensure all parties can be held accountable for their role in addressing the problems currently faced, not only by Black moms, but that impact all of humanity. This afternoon, you will hear sobering information presented by my colleagues regarding the poor Black maternal health outcomes we are challenged with. But where we are today is not where we have to be tomorrow. We as a people, we as a nation, we as a city can turn the tide if we all work together. There are some who fight for justice, equity, and equality by peacefully protesting in the streets. But we also need those who fight for justice, equity, and equality by sitting in the seats. We all must commit to coming to the table, and in some cases, bringing your own chair. Once at the table, data before us, we must collaborate and create a path to better outcomes tomorrow. Every person has a role to play. Wherever you see disparities, speak up, raise awareness in our places of employment, in our schools, our hospitals, our government agencies, and anywhere that human beings live, work, worship, or play. Each of us is accountable since each of us bears the societal, economic, national, and ultimately global impact of disparities. When it comes to maternal health, Excellis has been working in the community and working with our community partners. Recent examples of our support include our Maternal Health Bright Beginnings program. We have clinical staff such as nurses, behavioral health specialists, social workers who reach out to pregnant and new moms who are most in need. We attempt to reach out to all pregnant and postpartum moms in our safety net programs, such as Medicaid and Child Health Plus. We help the moms with the types of things that may impact their health. This includes navigating the healthcare system, providing education, and linking them to community resources if they need help with things like food, transportation to doctor's appointments, lactation support, and more. We also collaborate with their providers and reach out after birth to see if the new moms need additional help. Furthermore, we also assess moms for postpartum depression and encourage well child visits for newborns. Our goals include reducing the rates of preterm births, NICU admissions, postpartum depression, maternal mortality, and racial disparities. Now, to know how to get somewhere, you need to know where you are. You have to consider where the data says you are. Data is essential. This holds true for maternal health. That is why in July 2021, Excellis Blue Cross Blue Shield partnered with Common Ground Health and sponsored The Color of Health, the devastating toll of racism on Black Lives report. The report documents how racism, whether deliberate or unintentional, undermines physical and mental well-being, including maternal health. In addition to data, we must address the racial bias that we know results in a Black mom with a college degree having worse maternal health outcomes than a white woman without a high school education. The data is clear that in those cases, addressing social determinants of health will not fix the problem because social determinants of health is not their problem. The color of their skin and how they are treated because of it is. Today, I hope that when you leave the conference, you leave with the knowledge of the steps that you can take wherever your sphere of influence is to improve maternal health. Make sure you look, listen, and feel for signs of distress. Our moms are suffering and few are listening. Here are mothers. They are your coworkers, your sisters, your daughters, your neighbors, and your friends. Wherever you go and whatever you do, I encourage you to be an advocate for maternal health. Now, I am blessed to be able to introduce to you my dear friend and colleague, Dr. Linda Clark. The work of addressing disparities is arduous, and I thank God for being able to labor alongside of her as we work to improve the lives of our community. Dr. Clark is Chief Medical Officer of Common Ground Health. She's my fellow co-founder and serves as the chair of the board of directors for the Black Physicians Network. Dr. Clark is a practicing physician and longtime advocate for health equity and population health with over 25 years of experience in occupational and preventive medicine. Prior to joining the Common Ground staff, Dr. Clark served Common Ground as a clinical advisor and as a member of the Community Technology Advisory Board, also known as CTAB. She was a member of the African American Health Coalition for 18 years, including serving as co-chair. Dr. Clark has chaired the annual Faith and Medicine Conference, and now I place you into her capable hands. Dr. Clark.
Thank you so much, Dr. Kyler. It is always a blessing to be introduced by somebody so distinguished who's also a very, very dear friend and colleague. I'm going to get started right away because that Jerome Underwood took Dr. Kyler 6 minutes. So I'm going to rush through. And my job today is to talk about the data. You know, what does the data say? And why is that important? So I may go a touch faster than I planned, but that's okay. First of all, let's define the problem. Like Dr. Kyler says, without data, we can't describe what's going on. You know, so one of the things that's very alarming and many of us are aware of is that New York ranks 30th out of 50 states in its maternal death rate. So the rate of maternal deaths in New York rose actually between 2006 and 2015. So it's headed in the wrong direction. The numbers may look small, but clearly they're very impactful. And there's obviously, or not obviously, but there's a racial and ethnic disparities component. Compared to white women, Black women are 3 times more likely to die during pregnancy and childbirth in New York State. So what was the answer from the state? You know, in 2019, Senator Rivera pushed forth a bill creating the boards and the advisory council for the maternal mortality and morbidity to look at this alarming death rate and understanding how is it affecting women and clearly how is it affecting Black women. What does the data show? Locally in the Finger Lakes, accurate trends are really tough to come by. And like I said, the numbers are very small, so it's hard to make sweeping statements about that when the numbers are so very small, despite the huge impact. The maternal mortality is derived from vital statistics, and there are some problems with the way we fill out death certificates and whatnot. And Dr. Kyler reminded me that oftentimes when somebody dies 9 months later after giving childbirth, somebody who's filling out the death record may not recall that it's a year after giving birth that they need to be included in statistics around mortality. One thing that is interesting is infant mortality data is more readily available. And I think it's interesting because it can be related to the health of mom, right? Data related to prevention may also be helpful. I'm not saying that's the answer to everything, but you know, some piece of the puzzle lies in some prevention. Then I'm going to talk about morbidity because we talk a lot about mortality, which is death, but we don't always talk about morbidity, which is illness or disability. So in 2014, we had the first maternal mortality cohort. And what we found right off the bat, and this is the cohort of all the women that died in New York in 2014 that they went to study and understand what was going on. So we found out that Black, non-Hispanic Black women were overrepresented in the pregnancy-related death cohort. And, I alluded to this earlier, whereas births to Black women represented only 15% of all the live births in New York. Deaths to Black women represented over 50% of the pregnancy-related death cohort. Now that is shocking statistics. 2/3 of these pregnancy-related deaths occurred quickly within a week of the end of pregnancy, and the large proportion of that death occurred just the day after they given birth, so 45%. Women with full-term pregnancies, it was very interesting. There's a difference between Black women, non-Hispanic Black women, and Latino and white women in terms of when they died. So more likely women who were at full term were dying, and women who were white and Latino had births that were not, had deaths when they were not full term. So, 28 to 33 weeks is where the average gestational age was for non-Black women when they died. So Black women were more likely to die at the end of pregnancies. And nearly 1/3 of pregnancy-related deaths could have been prevented based on the reviewers. And there were reviewers in all the cases that they looked at. And they determined that there was something could have been done, something could have changed. And that's 1/3 of these deaths may have been prevented if we were able to make some change and way the community's response, how we were treating the patient, how the family intervened or was involved, the provider. There's something that could have changed to prevent death in 1/3 of women. So what are the causes of maternal mortality? Most common is infection and hemorrhage. And these are pregnancy related. So these are directly related to pregnancy or exacerbated or made worse by pregnancy. There are other pregnancy associated causes. So if you were pregnant and you're hit by a car, that is still a pregnancy associated cause of maternal mortality in New York. So you can see the vast majority was injury. And motor vehicle accidents, substance overdose were the top reported injuries. And that's across race and ethnicity. So I want to look at the births. I want to look at infants because sometimes the loss of an infant can be related to the health of the mom. So if we look at premature birth rates, so who's delivering earlier. This is now very local Monroe County data from the vital records, New York State, the vital records, the vital statistics, as I mentioned earlier. You can see that Black, having a Black mom, you're more likely to have a premature birth when premature is defined as less than 37 weeks gestational age. So both the Black and Latina women were birthing earlier than white women, and that's worrisome because younger babies are more likely to have sicknesses and problems that can impact them lifelong or result in this case in life loss. I know my colleague says, don't show that slide, it's really complicated. But all I need you to understand is to the left of the slide, or to the right of the slide are things that are more common, the causes of early death, more common out towards the right, less common towards the left. However, if you look at 1, 2, 3, 4, 5, this premature birth disorder is in the top 5 reasons for early life loss in the Black community. So it's not as but close as well in the Latino community as well. So it's very important and very impactful. And I should explain a little bit about what the years of potential life lost is. This is how likely you are to die at an age younger than a predicted age of 75. So if you die when you're 1, that's a lot more impactful than if you die at 74. So staying with infant mortality rate, you can see that it's much higher in African Americans, higher in Latinos compared to whites. The causes, the biggest slice is prematurity, as I mentioned before, and related conditions. But then also, if you look at prematurity and obstetrical conditions, together they make about half of the causes for infant mortality. And I think that an argument might be made that that is still, both tied to maternal health, mom's health. Quickly, at Common Ground Health, we often talk about the health inequity pathway. And, the end of that pathway results in morbidity, disease, injury, or death. When you go further upstream from those, you start to look at opportunities to intervene and prevent morbidity and death. So health behaviors, that's the sweet spot for preventive medicine specialists. And we like to tell you not to smoke, not to drink, exercise 150 minutes a week. And that is impactful, don't get me wrong, but I would like to talk about the fact that further upstream is where we can really get the biggest bang for the buck, so to speak. So when we're looking at issues of social inequities and structural inequities, that is going to really impact the whole population of people, and that's our sweet spot, and that's where we need to talk about what we need to talk about today. So, and I don't want to eliminate the behaviors. The behaviors are important, but I would argue that to be truly impactful, we need to look beyond that. But behaviors are, targeted, if targeted, may help with impacting birth outcomes. As I mentioned, it's late in that inequity pathway. Teen birth rates are actually been trending down. I don't know where they are from 2015, and maybe Sharita will talk about that more. But teens are more likely to deliver a low birth weight baby, as are smokers. Obesity is important in that it's a factor for diabetes. And if you look right here, I'm sorry, I'm rushing through some of these, but you can see that African American women are more likely to be obese than white women and Latino women. And still thinking about diabetes, Black people are more likely to have a preventable inpatient visit to the hospital than Latinos and whites, and Latinos more so than whites. So tobacco use, as I mentioned before, is important around low birth weight. And this is a disease of poverty. You see that Medicaid, people on Medicaid are way more likely to use tobacco, and people who make a lot less money, who often maybe on Medicaid, are more likely to use tobacco. So now I want to talk about morbidity, because I think this is where the story is. We're looking at mortality and we're frustrated because we know that there's quite a disparity, but the numbers are so small, it's very hard to tell what is going on. But morbidity is very critical in looking at the health of moms. So what is maternal morbidity? It's really any physical or mental illness or disease or disability that's directly related to pregnancy and childbirth for the mom. So they're not necessarily life-threatening or life-ending, but they can significantly impact the quality of life. And if you imagine a woman who's severely impacted, you've had a stroke as a result of your pregnancy, what does that do to the family? What does that do to the child that's being raised and the other children, the future children that may not be born? So, the impact morbidity has on mom and women impacts an entire population. And for every death that we see, up to 100 women experience one of those potentially life-threatening conditions. In New York State, we look at the severe acute maternal morbidity, and they have many other terms, and I don't want to dwell on them now, but these are acute problems during pregnancy throughout the standard kind of 42 days. In New York State, I'm sorry, I keep changing the colors on you guys, but you can always find Black people at the top of the chart, unfortunately. And this is looking at the morbidity rates by race and ethnicity. And you can see that Black people far exceed whites. Latino people far exceed whites as well. Asians, there's definitely there's something about, as Dr. Kyler said, that racism that is impacting morbidity in our state. So I'm showing you that structural equity pathway again, where to the right is morbidity and death, and to the left is, like I said, that sweet spot, that where we're looking at the social racial inequities, the structural inequities. That's where policy advocacy can take place. So I'm going to talk just a little bit longer. I know I'm out of time, but like I said, I'm going to borrow a little from Dr. Conyers' next session. I apologize. But we need to change. We need to change morbidity. We need to change mortality for babies and their moms. And how do we do that? I think my panel is going to talk a little bit more about this, but all women need to be cared for and deliver their babies respectfully and, in respectful manners and environments. Advocates for treatments have to be available. Women and their families need to be health literate. They need to understand and be educated so they can be advocates and they can be empowered to demand the care they deserve. And then early and unhindered access to high quality care, not just any care, but high quality care like we deserve. And I say we, because I've had my own experience, even as a physician, with being treated unfairly because of my race when it came to delivering my children. So, continuing, we need to get healthcare delivery models that address bias, whether it's conscious, whether it's unconscious. We need to standardize care. And, in every place we saw that hemorrhage, right, was number 2 on the list for why people, women die early after having a baby, have the standard hemorrhage cards in all hospitals. Pregnancy medical homes. There's lots of different, I'm not going to dwell on that because that's not my lane, and my panel's lane. And then doulas, and Sharita will talk a little bit more about that, and midwives, and we have Dr. Weber with us to talk about that. I wanted to spend a little time talking about impacting policy, but I'm going to let Dr. Conyers speak with her panel more about some of the opportunities that are already going on with expanding Medicaid, and then the Black Momnibus bill, which I'm not going to dwell on, but that's really a series of 12 bills. And my understanding, I think only one of the 12 has actually passed, and that was related to veterans care. And then expanding Medicaid for moms. The New York State is in the process of working on that. So I'm going to stop right there. And I feel very proud of myself for only going a few minutes over, because there's so much that we could dig in and talk about, but I want to get to my panel. So first of all, I'd like to thank my distinguished panel for joining me today. And I am going to start with introductions with Dr. Weber, Dr. Tracy Weber. Dr. Weber was born and raised in Brooklyn, New York. She graduated with a bachelor's in healthcare administration and a master's of public administration degrees in 1993. After working for 8 years as a budgeting and contracting analyst, she decided to return to school for nursing. She attended the Yale School of Nursing in 2000, and Dr. Weber completed the RN certification in 2002, earned her master's in nursing and midwifery in 2003, and she has worked as a staff nurse on Mother Baby antepartum high-risk obstetrics and labor and delivery units, in a private practice as a midwife, as well as hospital-based midwifery services. So I'm going to go ahead and give you the first questions, and I'll introduce the rest of my panel, Sharita Bullock and Dr. Gina Kyler, as they get their first questions. So Dr. Weber, and how are you today?
Thank you for the introduction, and thank you for having me today.
Oh, excellent. We're truly blessed and honored to have all three of you dynamic women. So here's a question for you. How exactly does maternal morbidity impact the family, and even more so our community at large? You know, I kind of hinted, I did more than a hint. I kind of slapped it all in the face with it during my presentation, but can you expand on that, please?
Right. And you did a really great job in summarizing that particular question. So when you think of maternal morbidity, it's any condition that's attributed to or aggravated by pregnancy or childbirth, and also includes postpartum complications. So Dr. Clark spoke about maternal hemorrhage, which is something that is pretty common in the Black community and causes a lot of mortality and morbidity. Mortality, of course, death, right? But in terms of morbidity, you think of people who have a hemorrhage and then they have severe anemia. So they have a really difficult time transitioning during the postpartum period, only because of severe anemia. There's also such a thing as a delayed postpartum hemorrhage. So these are patients who go home and for whatever reason, they hemorrhage and then they come back into the hospital in not great condition. So it's really important for us as providers to address anemia, you know, before delivery, and then our patients who are at risk for hemorrhage, just pretty much identify those and be, you know, prepared for that just in case it happens. But how these things affect the community, it's multi-factored. So like, for example, for a mom who has a pregnancy complication or childbirth complication or postpartum complication, it affects a variety of different things. Primarily, of course, the growth and development of the child. So like, for example, if a mom has a hypertensive disorder, that means that she needs to deliver early, or a mom who goes into preterm labor and has to deliver early, then that creates a strain on the mom and the family, because now she has to care for a premature baby. The baby's going to spend endless weeks in the neonatal ICU. This child may grow up with different health concerns because the baby was born too early, which may also put a strain on the family. She may not be able to work full time anymore. What if she is a single mother? Now she has to be home and caring for this baby. What kind of healthcare is this baby going to need? What is the cost of this healthcare? Is this child going to need special education services? So these are all the different things that we have to think about in terms of how it impacts babies. In terms of the family and the household, what kind of social supports does this mom have? Are there going to be changes in her relationship? Is her partner going to be supportive? Is she going to have childcare issues? So like, for example, you know, she may be a working mom, but might have difficult time finding childcare to help support that baby. Women who are pregnant are at increased risk of domestic violence. So now you have this additional strain of stress on that family where domestic violence is a factor. Loss in work, less productivity, less economic advantage, and then impoverishment results. And then for the woman, of course, there are different physical consequences as well. So, you know, different long-term effects could be anything from incontinence to something that we call fistula. So a woman has a baby and then has what we call a laceration. And if it's not repaired correctly, or if there's, you know, any infection there, then that causes a lot of problems afterwards, and it's called a fistula. Hemorrhoids, pain, long-term pain, especially for patients who have C-sections and repeat C-sections. Sometimes they can suffer long-term consequences as a result of those problems. Our patients who develop diabetes during pregnancy, did that diabetes resolve after the baby was born? Or now do they have long-term diabetes? And then the consequences of that. Also hypertension. So, you know, was that hypertension pretty much resolved at the end of the pregnancy? Was this something that developed over the course of the pregnancy? Or is this mom going to need long-term care in terms of her hypertensive disorders? So there's really no consensus. You know, when we talk about mortality, that's kind of easy to figure out. But when it comes to maternal morbidity, according to the American College of Obstetrics and Gynecology, there's really no consensus as to what, especially when we talk about severe maternal mortality, what we need to include, which diagnoses we should include, and at what point. So I think, and what they recommend, and I agree, is that healthcare institutions really need to take a really deep dive into some of the things that they're seeing occur, you know, whether it's hemorrhage or eclampsia or, you know, sepsis, and figure out what systems they need to change and put in place in order to change that. One of the things that I will say hospitals have been very effective at in terms of postpartum hemorrhage, we do have the postpartum hemorrhage carts, or at least we have like a whole container of stuff. So we know like, oh, this patient is bleeding a little bit too much. Everything is rushed into the room, and then we start working on that patient. There is a massive transfusion protocol, because back in the day when I was a new midwife, everybody just got a blood transfusion. And that in itself can create a whole sort of problems for the moms, right? If she's getting transfused unnecessarily. So that being said, now we have something called a massive transfusion protocol that gets put into place. And then there's also a sepsis protocol as well. So if a mom comes into the hospital and there's certain vital signs that kind of fall out of a particular range, then they start the sepsis protocol. So we're working on it.
Okay, thank you. You know, at this point, I would like to introduce Sharita Bullock, because I would like her to speak more about the voice of women in our community and the story behind the data. So if we could have Sharita Bullock's slides come up, I'll just introduce her. Sharita D. Bullock. I love Sharita. I love her family. She is the executive director of the Healthy Baby Network. She is, and you'll see in a minute if y'all don't know her already, she's then and dedicated community advocate who is inspired by her own birthing experience. She accepted a position at the agency known as then as the Perinatal Network of Monroe County. And she has worked with every agency grant and every program related role, progressing to the executive director position. Sharita's focus, fueled by HBN's mission, is to ensure, and that HBN is Healthy Baby Network, is to ensure every parent has the education, the information, and support needed to have a healthy baby born into a nurturing home. Her work centers on Black families and the racial health and birth disparities surrounding pregnancy. So she's going to bring us some more story behind the data that we talk about. What's the real life situation? Thank you.
Thank you. So I'm going to put up my slides and sort of talk while you're looking at the images of them. And what's important to me about this issue when we talk about maternal mortality and morbidity, and especially considering our topic, inclusive, equitable recovery, defining your role, is that there's nothing more squishy than talking about pregnancy and birth when you're talking with parents. People don't want to talk about, and I think some of it has to do with the connection to sex, but when we specifically look at the issues of maternal mortality and morbidity, and Dr. Kyler and Dr. Clark have painted the broader views, I'm going to bring us right down into the field, to the flowers, right down to the root, to the seed of this issue. And I think that part of this is that our starting point is wrong. We often talk about maternal child health, and in our community, we don't really have moms having babies alone. They come attached with dads, and fathers aren't included in that picture. So we talk about paternal maternal child health and how we bring into full view the partners, the families, and the other supporters of moms to this issue. And so, you know, we first began doing this work and talking to people. And when you talk to families who've experienced either a near miss, the mortality, or death, the morbidity, what we commonly hear from those families are that we knew something was going on. We didn't really know what. We didn't know the medical language or jargon to use to really get the providers to act. And by the time the provider began to act, it was too late. And we had a loss, or it was, things were moving really fast. And thank God we were able to get the help when we did, and experienced a near miss. And what is so important about that is understanding that data alone, and with all due respect to all the comments that have been made about data, data alone can be dangerous because it doesn't tell a full story. In order to really convey what is going on and to really tell a whole story, you need the data point of how big or how broad the issue is and maybe what brought us here. But we also need the information, that same data coming from families around what are our behaviors? How are we experiencing and expressing our culture? What are we doing in terms of what we're considering movement and what we know, and who's engaged in our team, and what are all of our resources and our assets in terms of people who come to bring help and comfort. So when, and I came to this as neither a person who had recently delivered or a researcher trying to understand. So then when we would talk to providers, what we would hear from providers are some of those causes that Dr. Clark was talking about on our last couple of slides, and saying, this death or this near miss was really the consequence of poor health prior to pregnancy. And so as a Healthy Baby Network coming in to address these issues and really talking about what's going on, what we then do is try to partner both the data, facts, numbers, pieces with the stories, the data elements that come from the families who are engaged, and then try to create with parents crafted interventions that really speak to both of those things. And so, we don't see, and I, always like to put up images of Black women, of pregnant bellies, because certainly if we ask the Black woman, and in particular, a pregnant woman, who her body belongs to, and if I asked all of you, my hope is that you all would say it belongs to her, it belongs to her family, to her community. It's her body. But then when it comes to peeling apart all of these issues, we don't listen. We don't take into account with the same weight and measures the data and the information that comes from those moms. So what I really want to do on this slide is spend some time talking to you about some of these moms. This is an issue that transcends zip code where people live. Yep.
We cannot see your slides.
Oh, no.
Okay.
Can someone, they're on my screen and I can't see any of you. So I'm wondering if our IT team could put them up and go to that second slide, and I will keep talking, and hopefully these images will come up, because it's important that we put faces to this crisis, and it is a crisis. So we talked about what those numbers look like. But what's really important is that we understand that what this means when we talk about maternal mortality, it means that we're sending babies home from the hospital with their families without their mothers, that these children are growing up without, and I'm thinking back to our keynote this morning, Simeon's presentation, where he talked about Margaret Ward and how her touch healed her baby. These are babies who are going home who won't feel their mother's touch. And so on the pictures, and I hope that we can get those up, Tatia Oden French was 32. She and her baby died in December 2001 during childbirth. Her baby did not go home with her family. Kyra Johnson, who was 39, who was a world-class traveler. She was educated. She ran marathons. She raced cars. She skydived. She and her husband had high earning incomes. She knew her body because of the marathons and the trainings. And still, she had a baby who was 2, their first son, Langston. And then at the birth of their second son, she died shortly after delivering their second son on April 13th, 2016. Shalon Irving worked at the CDC as a researcher. She had been in service to our country. She knew her body. She knew infectious disease. She knew Warning signs, she was healthy. She attended all of her doctor's appointments. And yet on January 28th, 2017, she died after childbirth. Kalista Johnson, 32, died on June 7th, 2017. Erica Garner, the oldest daughter of Eric Garner, whose death really kicked a movement, was 27 when she died after 3 months after giving birth to her son, who she named after her father, on December 30th, 2017. Dawn Fleming was 31. She died on December 8th, 2014. Yolanda Shapira Kidma was 35 when she died after giving birth on July 27th, 2020. Amber Rose Isaac died. She was 26 on April 21st, 2020. Amber was excited and looking forward to the birth of her first child, had spent months preparing, had a nursery all done and set up for her daughter, and was married. So, and then Shanice Wallace was 30 when she died after giving birth to her daughter on October 22nd, 2020. All of these moms, except one, left children that will never feel their touch to go home from the hospital with their families to be raised. And when part of why this issue is so difficult, we as a group of health and human service providers, and this is me helping you define your role, are really great at crafting programs and interventions and aiming them at consumers. And there certainly are some things that we need to do with families to prevent death, but that's not the whole story. The primary target audience of the interventions that we need to craft, take a breath, is us. Again, I'm helping you define your role. You can take the pictures down. What is so important about this issue is that we break down and really understand the causes and the drivers and our contributions. This is the hard part of this, our contributions to those deaths. So these causes and things that Dr. Clark was talking about, whether we're talking about embolisms or hemorrhages, being Black is not the risk factor. And I'm gonna say that again, and I hope that those of you who are writing notes will write it down. Being Black is not a risk factor. The risk factor is the way that our system responds to Black and brown people. That's the risk factor. The risk factor is that we've not learned all of the toolbox, the kit of interventions that we need, and the determining information that helps us apply those interventions in ways that save the lives of Black and brown women and birthing people, and help us then create interventions that allow us to swim further upstream and really focus our work in prevention. And we really have not been able to, and it's not one or the other. You know, this is both and. Again, I'm helping you define your role. So when we think about what our responses as a community are to these issues and what specifically Healthy Baby Network is doing, we're partnering with families, centering in on their lived experience and their expertise around what's going on with them, what's happening, and take a breath. I'm helping you define your role. Who's making it worse for them? Who are the non-advocates? Who are the people who are not disrupting? So that, because this is not about pointing fingers, this is about saving lives. And when we get right down to the seat of the matter and decide, you know, what are we going to, where are we going to invest? What are we going to focus on? How are we going to change and, you know, not just intervene, but really get upstream and prevent? Then we'll begin to do some different things. So Healthy Baby Network has a set of community health workers, both men and women, working both with mothers and fathers, partnered with them to do education, to help them identify other needed resources and provide care for them during and after pregnancy. We, as many of you may know, started a Black Doula Collaborative 3 years ago. And from that Black Doula Collaborative, provided training for women in our community, who primarily were not health or human service professionals. They were Black women who had been pregnant or knew how difficult it was to be pregnant and not have resources and supports, and were willing to do something about it. So we talked this morning about culture eating strategy for breakfast, but really focusing in on culture and values with a deference for action and evolving, right? So how do we do that? Centering in on families, the doulas are working both with the community health workers and to provide education prenatally, support at birth, to be there with families. This is not about us pointing fingers at doctors. It's about us working with doctors to understand what's going on and how we move that forward. So I'll stop there, Dr. Clark. I saw your note.
It was supposed to be private. Okay. Thank you so much, Sharita. I really appreciate it. And I want to get everybody else in on the conversation, but truly we appreciate it because the story behind the data is the story, right? The data only supports that story. So thank you so much. Fortunately, I don't have to introduce Dr. Kyler too much. Mr. Underwood started to introduce her, but I do need to continue to reflect on the fact that she is my co-founder with the Black Physicians Network, along with Dr. Nana Duffy. But she, as we already know, serves as the executive, I'm sorry, I'm giving you a promotion. The Vice President of Health Equity and Community Investment for Excellus Blue Cross Blue Shield. And she sets the organization's direction to promote health equity, cultural sensitivity, and community health. She's a fellow of the American College of Physicians and Alpha Medical Honor Society member. And as I said, most importantly, she is the co-founder and past president of the Black Physicians Network of Greater Rochester. Dr. Kyler, you're a doctor. But I want to hear about the money. Who bears financial responsibility for seeing the innovative programs like Sharita was beginning to talk about with the potential for saving lives or improving maternal health are actually properly funded? Who should be responsible for that payment?
Well, you know me, I believe in sharing. I believe everyone bears the financial responsibility. If you think about it, there's a cost to disparities. There's a cost to death, disability, and the harm that happens to mothers and their infants. Some of these costs are visible, but there are costs that often go unnoticed. The costs are societal, impacting families and communities, economic, impacting businesses and the ability to conduct business or create jobs, national, impacting our collective ability to leverage the inherent potential of every human being to help us thrive as a leader in the world. At every level, we, the people, must advocate for resources to be allocated to supporting the work that is needed to address maternal health. You fund what you care about. If we say that we all care about maternal health, there should be tangible evidence that we are willing to sacrifice our time, talent, and treasure to address maternal health in ways that lead to improved outcomes. And we must hold ourselves and everyone in our sphere of influence accountable for their role in addressing maternal health. Simple questions such as, what are we as an institution doing about maternal health? And what am I doing about maternal health? Are questions that everyone can ask. There's a role for each individual and each organization. But the first step is assessing what is being done and then identifying the role you can play in improving maternal health and who you can partner with to do that work.
Okay, you are obedient to time. Thank you. Dr. Weber, do you want to weigh in on that at all? Or Sharita?
In terms of identifying the costs, I agree with Dr. Kyler, especially when you think about identifying what is happening in terms of what programs are already there, if any at all, and then looking at where the deficits are. So it's really important to identify where the service delivery gaps are. What are we doing well, but what can we do better? And then putting the money there. And then also, it's really important to me, like when healthcare institutions, including mine, set up these different programs, I always ask them, did you have anyone in the community at the table? Because we have a really bad habit of identifying service gap deliveries and saying, we're going to put this program and we're going to put it in the community and we're going to do these great things without asking the community if that's really what they need and if that would work for them. It is my biggest pet peeve. And I know that people do it with the best of intentions. There's no malice there, but we can do better.
It is arrogant, isn't it?
Yes.
Very paternalistic. Sharita, what about the money?
So I would add to Dr. Weber's comments and say further that, it's parents, right? We're centering in on lived experience. So we want parents who recently delivered being the loudest voices at the table and being the ones who are not only talking about what it is they need, but what it is that we should be creating and doing. And so, I couldn't leave this forum without talking about our vision for a Black Birthing Center here in Rochester to be able to provide culturally responsive, evidence-based intervention of structural racism that's embedded in our healthcare systems, policies, practices, and care delivery. And I would say that this is not about, again, pointing fingers at any one group of people, but really saying that our goal, again, helping you define your role, is to, get involved and work with people who are willing to help us really address, and our goal is to eliminate racial health disparities and especially preventable death. Reducing is on the way there, but reduction is not our goal. We need to be focused on eliminating preventable death in our community and really focusing in on where we have the most vulnerable situations and circumstances, and that is with Black families. It's with Black birthing women and men who are, partners and fathers, and who have long in our community been ignored. And so we're focusing in to provide those services for dads, and in particular for those who are now raising their children by themselves because they've experienced loss. I talked about a few moms, but by no means are those moms the only moms in our community or our country who've experienced losses. And we know that within our program, within our agency, within our community, women are experiencing those situations and families are experiencing that loss every single day. There are women right now who are in hospitals in our community birthing with issues.
Okay, thank you. So Dr. Conyers, we're going to pass that question to you for the next panel too. We want to talk about the money as well. You know what, back to Dr. Kyler, we're not using data is not a dirty word. We still like data. How must data be shared so that the community interventions can be planned and evaluated? Who's going to get it? Who's going to review it?
That's a good question. Well, before we share data, I think one of the first things communities must do is ensure that accurate data is being collected at all levels. Specifically in this case, we must ensure that the data regarding maternal health is accurately captured from all segments of the care continuum. So we know who we want to capture the data about. The next step is clearly defining what we need to capture at each segment of care so that we can use that data to comprehensively drive meaningful change. For example, making sure that questions about racial bias are included in patient and family experience survey data in ways that can lead to strategic focused initiatives to address specific problems. There must be transparency with the data to ensure that light shines on all aspects of care to facilitate collaboration and creation of solutions to address the problems. We must have a process that supports accountability while giving institutions and communities a chance to do better and metrics to measure that improvement. This way we can collectively address the challenges, but at the same time, we can collectively celebrate the successes. We must move from working in silos to working as communities in safe collaborative spaces without fear of sharing organizational challenges. Using data, we must ensure that we develop metrics to measure our interventions to ensure that we don't create solutions that are analogous to pouring gasoline on a fire in an effort to put the fire out. We don't need just any solution. We need to make sure that we implement the right solutions. And that requires scrutiny of the work from numerous vantage points. And that only happens when data is shared transparently.
Okay, thank you. So I have a question about medical conditions. So Dr. Weber and Dr. Kyler, we'll let you weigh on this. How do we support Black women with pre-existing conditions? You know, and we know there are a few for Black women, right? I talked about we're more likely to be obese, but we're also more likely to be hypertensive, you know, diabetes. You know, how do we support those women who desire families? Dr. Weber, then Dr. Kyler.
A lot of times when pregnant women come to me, especially if they have some type of pre-existing condition, or when women come to me, they're already pregnant. So it's really important during GYN care and when they go see their primary care providers that we start talking about preconception counseling. So we talk to them about, what are your plans? Like, you know, what are your plans in terms of pregnancy and childbirth? How do you want to space out your pregnancies? Okay, you want to have a baby within the next 2 years. So this is what your blood pressure is looking like today, or this is what your diabetes, your blood glucose is looking like today. So what are we going to do to optimize your health so that you have the best pregnancy outcome? And the problem is, by the time they come to me, they already have a long list of different things that is going on, as well as a long list of medications. And then it involves more surveillance and more ultrasounds and more tests and things that can possibly even get missed because it really gets complicated. So then, you know, me as the midwife, I'm going to make sure that doesn't happen. I'm going to co-manage that patient with maternal fetal medicine and back and forth and in and out, and then trying to time that delivery so that mom and baby have a safe delivery. And then we're talking about induction of labor before mom's body is really biochemically ready to do that. So then you have this long induction process, which can lead to an hemorrhage. You know, it's just like this whole steamroll effect. So I really think us as OBGYN providers and primary care providers, when we're taking care of women, that we really need to address these issues before they are pregnant. The one thing that we really didn't touch on today, and I'm hoping that we could talk about it just for 30 seconds, is also mental health. You know, we talk a lot about diabetes, we talk about hypertension and thyroid disease and everything, but, you know, women are struggling. Black women are struggling, not just in terms of their own health and their own socioeconomic status and, you know, juggling work and kids and everything, but you just turn on the TV and you get depressed, right? Because, you know, of the racial tension that's going on, not just locally, but nationally. So just the thought of trying to get through a pregnancy and you have all these things weighing on you, it's really hard.
It is. And at the age of 56, I really don't want to think about that. Dr. Kyler, you're on mute.
Yeah, thanks. I think one of the things that always has struck me in my years of primary care practice is how when a woman becomes pregnant, it is as if she has now become a alien from another planet. And there's this disconnect that happens with the primary care team and the OBGYN or maternal fetal medicine team. And the OBGYN and maternal fetal medicine team in many cases don't want to manage things that are historically primary care disorders that are chronic, and the primary care team doesn't want to deal with things that may even remotely have to deal with the baby and pregnancy. And I think we have to collaborate and we have to be intentional in working together to take care of the whole patient. And I agree with Dr. Weber. You know, we know that if someone, before they even become pregnant, has a history of anxiety, that, you know, they're going to be more likely to have postpartum depression. And we can be intentional in preparing for that and making sure that they have the support that they need. But the other part of it is making sure that we educate and empower patients to know what the significance of their chronic conditions is in their pregnancy, so that they themselves can make sure that they know how to manage those conditions, where to ask for help, and how to be a better advocate. And I think that working together as a team, patient and providers, we can see better outcomes for our patients.
So, Sharita, I need you to weigh in on this, because it's not just a patient-provider story, right? Who else needs to be involved to help with predicting a successful pregnancy?
Yeah. And I think too that one of the things when we talk about mental health, although it's not the only contributor that I'd add into this discussion, is that families and support people are usually the first folks to know when something is going on. It's not always that a mom, certainly there are some, but it's not always that a mom will have a prior history or experience with depression. Sometimes pregnancy in and of itself will bring it on. And let us not forget that we're in the middle of a pandemic. So when you begin to introduce that as a lens, then there are a host of other conditions and situations that we need to be thinking about and on the lookout for. So there's violence, there is isolation from being home alone, there are having everyone in your household all the time, oftentimes asking for and needing things, right? So there is, when we think about how we use socialness or togetherness to manage some of these things, we don't have that in the middle of a pandemic. And so, we also need to acknowledge that there are many women who are not engaged in our current care system. And so oftentimes their entree is pregnancy. And so thinking about how do we capitalize to build strong, positive connections and relationships during that time so that there's an opportunity to continue to address some of the issues that show up during pregnancy.
Thank you. The chat is hopping. I've got questions, but I'm going to ask some of this another medical question. This is something kind of close to my heart, and they're talking about racial bias in equipment used to assess and help and monitor women. But I would expand that a little bit more. How about racial bias in equipment, but tests, medical illustrations, right? We're seeing a lot about that lately. Where should we be looking? How should we be looking at race, and does it matter when using equipment, tests, illustrations, etc.? Dr. Kyler, should I hit you first?
Sure. Thank you. I think that's a great question. I think we have to look at tests, diagnostic tools through the lens of historical cultural context. And a lot of these tests that we use, a lot of the tools that we use every day were developed during a time or implemented during a period where the Black body was considered substandard, subhuman, lesser than. And this concept persists today, where we have subclassifications for measuring your kidney function or your lung function or any other thing that we can measure. And we need to get to a point where we turn to human functions and we recognize that the body is the body and we have to see it as such and we have to treat it as such. Bias is something that everybody has. And to say that we don't have bias in our algorithms, in the way we manage patients, in the way we perceive severity of illness in various patients would be a false hypothesis, right? And so we have to make sure with intentionality that we are saying, what are the inherent biases that we know about in these tools, and what are we going to do to address them? And if we don't ask those questions, we will see the same biases persevere at every level that we engage the system.
Thank you.
Even from personal experience, I was recently prescribed a medication that to control, because I have hypertension, right? So to control my blood pressure, but I knew that it caused angioedema in Black people. So I wrote my doctor and I was like, I'm not taking that. And she's like, why? So I shot her an article. Oh my God, thank you. Not my physician does not look like me. She didn't know that. So I educated her, right? But these are the things that we need to be aware of in terms of medical equipment and treatment options, medications, and how we recommend dietary changes and everything. Like, how does that person's, not only their physical makeup, but also their culture play a role in how they're going to respond to what you're recommending and what you're doing?
Thank you.
I realize I'm not a doctor, but may I also just weigh in on, part of, I think, what helps address some of these issues are having more providers of color in our community. And we don't have great systems for a pathway into medical and research.
Good. Thank you. So we're winding down, and I am upset. So, but I'm not going to take too much of Dr. Conyers' time. I'm going to give one last question to everybody, and keep our little 2-minute rule into account. Sharita. So let me stop. Actually, I'm gonna give Sharita just 1 minute before I do this question. I want to hear more, just 1 minute, about the success or the impact of the Black Doula project. Are we there yet? Are we starting to see something, or we need to wait and be patient?
So we're not there yet, but there are great things that are happening. So we have doulas that are now going to be embedded into the medical care teams as part of the regular care. And I'm doing regular with my air quotes because, what we really focus on is having the right care for mom based off of what her situation is. So everyone is not going to get the same thing. They're going to get the things that they need. Talking again about, equitable recovery here. But really that we have the attention where people are, there's an energy and an urgency around doulas in our community right now is a success. Having doulas that are the same color, sharing same experience, sharing, many of them live in the same, many of our doulas live in the same neighborhoods that our moms are from. And so having those same sort of shared experiences as an entree into building relationship has been incredible. Having the attention of medical providers who are willing to listen and work with us is an incredible experience. That is not always something that we've had. And having systems that are open to helping us work through all of the issues that come with that. So doulas are non-medical professionals. And so being able to build those relationships and then begin to treat moms and then look at incredible outcomes. Not there yet, but it's on the way. I'm confident.
Okay. All right. So, we're down to 2 minutes. So I think what we'll do is just I'm going to challenge y'all to give me a 1-word or 1-phrase answer to this next question. So y'all know what the question is, so don't act like you're surprised. What is the single most important change in healthcare services that must occur to improve Black maternal health? Ready? Dr. Weber, go.
The short answer: address systemic racism and unconscious bias in healthcare.
Okay, don't tell me she took your answer, Dr. Kyler. You go.
One word. You know what? I would say collaboration, because if everybody collaborates, we can hold each other accountable and make sure we use data and data-driven solutions to achieve what we need.
She had to get that data word in, didn't she? And don't be mad at her, Sharita. What's your 1 word or phrase?
Not at all. I'm not anti-data. I just want the right data. My 1 word is not 1 word. It's prepared providers, which means that they are, knowledgeable about the community that they are practicing in, knowledgeable about the patients that they're going to be serving, and knowledgeable about the assets that those patients, women, families come with, because I think so often we just don't believe that our patients and our families have assets already at play. And I'm done.
All right. Yeah, I'm so impressed with you guys. I'm so proud. We need to continue this. Mr. Underwood, we expect a return invitation at some point for something to continue this conversation.
Dr. Clark and Dr. Weber and Dr. Kyler and my sister Sharita, y'all know y'all don't need an invitation.
Okay.
Just show up. You don't need to call before you come. Just show up, because we're family and we're kindred spirits in this work. I shouldn't even turn my camera on, because I don't have expertise that you all have in this issue, but just as the host, I'm so gratified and grateful for you all. And as a matter of fact, since you're doing such an awesome job, Dr. Clark, I'll have you just segue us to the part B of the panel. So I'm just going to get quiet since you told people about me at the start. It took you a couple of minutes, but anyway, we'll talk about that at another family discussion.
Okay, gotcha. Thank you so much. And frankly, it's awesome and what Jerome Underwood told us at the beginning is to have a group of women talking this through. And here I'm going to get to introduce you to another one of my favorite women, Dr. Yvette Conyers. I would call her my ride or die, but every time I look at Facebook, everybody else is her best friend. But when it's time to work, that's who I call. Dr. Conyers has been a registered nurse since 2003. I can't believe that. And a certified nurse practitioner since 2013. I laugh because when I got on, somebody changed my employment to Anthony Jordan on my picture. But that's where I first met Dr. Conyers, at Anthony Jordan, when she was an LPN, and now she's a doctor of nursing practice. So she's Dr. Conyers. Her interests include addressing the social determinants of health in the work. I should have read this in advance. In the workplace, in work towards social justice, okay? She is passionate about increasing students from underrepresented groups in nursing. And in her role as president of the Rochester Black Nurses, there's a Black Nurse, RBNA, Rochester Black Nurses Association Incorporated. This is one of her goals. I am very happy to turn over the next panel to Dr. Conyers, who will find out where the money is coming from. All right, thank you so much.
Thank you so much. Hopefully, can you all hear me okay? All right, great. Thank you so much for the introduction, Dr. Clark. I will make sure when I reactivate my Facebook page that you are made sure you are known as one of my BFFs, okay? That was an awesome first half of the panel. Thank you so much, Dr. Weber, Dr. Kyler, and Ms. Bullock for your words of inspiration and just letting us know what the truth is and what we need to do. So I'm excited for the second part of this panel, really taking a look at featuring our local advocates and local legislators and elected officials who we are going to take some time to talk about policies that are out there and practices that have contributed to some of the disparities that have been highlighted so well in the first part of our panel. And then looking at how can we advance models of care for Black birthing mothers out there. And we're going to talk about the money a little bit because that is so very important. So I am excited to have with me three very important folks. The first, I'll go ahead and introduce Assemblyman Harry Bronson, who was the first elected to the New York State Assembly in November 2010. The 138th district includes parts of the city of Rochester and the suburban and rural towns of Henrietta and Chi-Lai, where I reside, actually. Harry's passion for social justice, equality, and fairness has defined his public health service, legal, and business careers. Before elected to state assembly, Harry Bronson served in the Monroe County Legislature and held leadership positions during their entire career. Harry oversees economic development and business regulations currently throughout New York State. So welcome. So excited to have you with us today.
Dr. Conyers, so happy to be here. And boy, what a pleasure it was to listen to that panel that we just listened to, all those experts who are so much more knowledgeable in this area than I am. So I'll do the best I can.
Thank you. Thank you very much. I also have two other guests with us, and I will go ahead and introduce them just prior to their first question. So I'll go ahead and start with you, Assemblyman Harry Bronson. And just a reminder, we do have about 2 minutes to respond. So keeping that in mind, I have a question for each of you. And then if we have time, we'll go back and do a second reply of question. So thank you very much. So the first question to you, and we've heard about legislation that's out there a little bit earlier from Dr. Clark, but what current legislation are you sponsoring or co-sponsoring which speaks to Black maternal health?
Sure. So first of all, let's talk about some of the things that we have done. I was a co-sponsor on a bill that established a maternal mortality review board. And the purpose of that was to convene a group of medical experts like those folks we just heard from in the first panel. And they're charged to assess factors related to maternal mortality and morbidity in New York State, and to develop strategies that we can use as a state to address the the health concerns that have arisen and death, of course, and have strategies that would turn that around. In addition, I'm a co-sponsor on a bill that got signed into law this year, just recently, and this would establish a procedure for the approval and operation of midwife birth centers. We just heard from one of the panelists earlier how important it is to have those types of birthing centers available, and we're looking to establish one. I think it was Sharita that said looking to establish one here in Monroe County. This would streamline the process for these birthing centers to establish and operate in New York State. So that should help us here in Monroe County, and then to actively work to reverse our state's really devastating maternal mortality and morbidity crisis that we're facing. It's really our responsibility to make sure that we offer quality health care, and this is one venue to do that. We have another bill that is still pending. This would expand Medicaid coverage, period, for certain pregnant women to a year following the end of the pregnancy. This made it through part of the legislative process, and then a portion of it got in this year's state budget that would expand healthcare coverage for pregnant women, but it didn't go as far as we wanted to in the legislation. So we're going to continue to work on that. And one of the panelists again mentioned how important it is to have Medicaid coverage for this. And then lastly, I'm going to bring up mental health. Actually, one of the other panelists who's on here, Senator Sandra Brooke, and I have a bill that would allow mental health practitioners to diagnose and develop assessment treatment plans. This would create additional access to healthcare. So we're looking forward to getting that passed. There is right now, their ability to do this within their scope of practice sunsets in June of this year. And we've got to make sure that we set up a permanent situation so they can continue to do that. But the governor just on, I think it was 13 minutes before midnight on New Year's Eve, signed a bill. Actually, it was the day before New Year's Eve, signed one of my bills into law on the mental health that would authorize certain mental health practitioners, those would be the mental health counselors, as well as family and marriage therapists, to directly bill Medicaid and receive reimbursement for those services. So when it's with family and marriage therapists, if a family's going through mental health situation as a result of a pregnancy or health illnesses or something of that nature, this would allow them access. And then another bill I'm just going to mention really quickly, that this would require Department of Health to review and issue a report on the effects of racial and ethnic disparities in infant mortality. So we would like to have that, and then there's a companion bill regarding breastfeeding, and that bill got signed into law. So those are just some of the measures to try to keep it within 2 minutes.
Yeah, thank you very much. Those are really, really good things that you are doing. I'm excited to learn more and hear more with one of our speakers as well about the Midwives Birthing Center that you mentioned, and how we can be using that as advanced models of care to address the health inequities that we see with our Black birthing mothers. So thank you for that introduction. I also think you highlighting the mental health, and also Dr. Weber brought that up as well, is something we need to continue to address in looking at those assessment plans, but also looking at billing and ensuring that that is removed as a barrier for folks who need mental health assistance. So thank you very much. At this time, and feel free to please stay on, Assemblyman Bronson, I'm going to introduce Senator Sandra Brooke, who is no stranger to serving her community. We have seen her very, very visible in our community. She was elected to represent the good people of New York's 55th Senate District in November of 2022. Senator Brooke is the chair of the Senate Committee of Mental Health, which we just heard about, and looking forward to hearing about that a little bit more, and has made significant improvements in addressing and accessing life-saving resources as a legislative priority. So thank you so much for that. To that end, you proactively find opportunities to address the intersection of mental health with topics such as education, substance abuse, healthcare, Black maternal health, specifically here today. She serves on the Aging, Alcohol and Substance Abuse, Education, Elections, Health and Women's Issues Committee. And you also co-chair of the Joint Senate Task Force on Opioids, Addiction, and Overdose Prevention. Woo. So thank you for being here with us today, because I know you are very, very busy. Appreciate your time. I'm going to ask you the very first question that I asked Assembly Bronson. What legislation is out there that you are sponsoring, that you are co-sponsoring, that you are trying to push to for this community to address that?
Absolutely. And it's good to see you, Dr. Conyers, and I loved being able to watch some of the previous panel. You know how you know you're doing the work right is when none of those names were new. Those were names that are populating my calendar and in my inbox, because we've worked really closely with our local network of providers and activists and people who have experienced this, basically to make sure that our legislation is always responsive to the needs of people who are most affected. And in this case, we're talking about Black birthing people and Black mothers being the most affected, and their children. The great news is it's been a pleasure to join in my now second year, first term, and to work alongside Assemblymember Bronson on a lot of what he described. He shared a number of bills that we've been able to work together on. And I think it is important, obviously, as chair of mental health, that we focus on that as well, and the intersection of mental health with physical health. So a few things I want to focus on from my perspective, because a lot of them, again, Assemblymember Bronson talked about, but one is specifically around maternal mental health. And, you know, over the past about probably almost the past year at this point, my team and I have really started to dive deep into this issue, because as the Assemblymember pointed out, historically, the state hasn't done a terrible job of outlining the need to study, like with the Maternal Mortality Review Board, and really putting forward legislative recommendations for how to address this. But at the end of the day, we still find ourselves with me as a Black woman, regardless of what college I go to, regardless of how much money I make, regardless of being an elected official, that I'm still nearly 400% more likely to die in childbirth than a white counterpart. So clearly we have not done enough. And one of the things that really struck me when we started digging into this work was that while I believe we have gained more acknowledgement and acceptance around the fact that these mortality and morbidity numbers are abhorrent, I'm not hearing enough around the mental health for our birthing population and our Black birthing populations. And when I saw that the most common complication, either while pregnant or postpartum, is actually around mental health, and the effect that can have on not just the birthing person, but the child, I really thought that was a place that we could dig in. And so I have introduced a number of bills specifically around that. First of all, in order to have parity with our physical health issues, to have that with mental health, we need to study it at the level that we have studied physical health. Therefore, we've introduced a bill around creating a maternal mental health group, specifically targeted at talking about and studying the effects on the mental health of our birthing population in New York State, because the expectation would be that we would come out with recommendations to further legislate around that issue as well. The other thing that we really looked at was there are these postpartum depression screening tests that many providers conduct, that we heard about, and they do it both during pregnancy and after. But one of the things that we've learned, right, and we've talked about this a lot, historically, our systems, especially our healthcare systems, have been created, our tests have been created, we heard about this almost exact issue, our tests have been created without us in mind. So I'm taking a test that frankly has never been tested on a Black woman. The questions you are asking me about depression screening may not be as applicable to me as they are to, generally speaking, white women who are generally tested when they're creating these mechanisms and these tools. So this other bill is to actually study the disparate impacts of not including us in the creation of these tools, and making sure that we are asking questions that are intersectional and that will actually get answers as to what is the mental state of this birthing person postpartum. So those are two things that that we are trying to push forward to ensure that we are considering this issue more holistically. And the other piece of this I wanted to talk about is the same thing as Assemblyman Bronson just talked about, this idea of getting Medicaid coverage, right? I was lucky to join probably almost everybody, you know, on these panels with Senator Schumer and Attorney General Tish James earlier this summer. Hard to believe how hot it was that day, given how cold it is today. But you know, he talked about on the federal level, the Omnibus Act, and talking about trying to extend Medicaid. Well, you know, the beauty of living in New York State is that we are often ahead of the game when it comes to federal legislation. And so for anyone who's been following that on the state level, we have fought in previous budgets to get that through. And I'm happy to report that this week, as I sit in the Senate Health Committee under Chairman Gustavo Rivera, we did pass this bill again through the Senate Health Committee, and we got a lot of really strong and positive responses from folks who are paying attention to this issue. And so obviously both the Senate and Assembly, we hope to be able to move that forward because, you know, again, that's not just about the birthing person, right? That's also the child of actually having that year of coverage. And then the last bill that I've just introduced in the Senate is about increasing these screenings for the birthing person and really encouraging providers to do so sooner. So a lot of studies, a lot of providers have come out to say we need to be checking in with our birthing folks earlier rather than later. And really within those first few weeks, we need to be checking in with them. And so, so this third bill that I just introduced in the Senate would do just that, really encouraging providers to do it sooner so that we can catch if something is happening, you know, for this mother or this birthing person and be able to get them the help that they need.
Thank you so much. You know, I hear from you, you know, saying a couple things again, making mental health a priority, as in all of the other areas of health. How can we continue to make mental health a priority in this area? And then inclusivity, right? So a lot of the tools that you talked about in the screening, again, were created by folks who weren't inclusive of those who it was going to test. And we heard about testing earlier on. So I think that is great that, you know, those things are continuing to be worked on at the Senate level. So thank you very much for sharing that. The last person I want to bring up on this panel is Jacqueline Lindsay, who is a licensed master social worker, a certified lactation counselor, doula, program development director at Healthy Baby Network. She has a unique passion for maternal child health, and her work is aimed at reducing and eliminating maternal mortality and morbidity rates among Black women. Currently, Jacqueline is the program manager for the community-based doula program and is starting off the new year by training a new group of doulas who we have also heard about, who will be providing no cost doula services to women of color in Monroe County. And we'll be getting to funding sources and those like that and another question, but welcome, Jacqueline. And so my question for you is, what are some of these future services that maybe we heard of, but love to hear your input, that are needed to address Black mothers?
Thank you. Thank you for having me, and also honored to follow all of the speakers before me. So I think definitely a big one is normalizing and amplifying the role and importance of doulas, specifically Black doulas. So currently doulas are not too widely accepted and welcome. So embedding them and incorporating them into the care team with a goal of them becoming the norm is really important. The presence of Black doulas can be so empowering to families who have had bad experiences or been treated poorly and experienced racism by medical providers in the past. Also, there is really a glaring lack of representation in the lactation field. And so in Rochester, there are 0 lactation consultants of color who are working in the hospital systems. And so when you think about the history of breastfeeding with Black women stemming from slavery when we were forced to wet nurse at the expense of our own children, and then leading to then not having that support because not having that experience. Representation is so important. So when you see someone who looks like you and you feel can understand your experiences, that shared understanding and mutual respect can really make the difference. Another thing I think it's really important to emphasize is that so many people think the disparities we face are primarily an economic issue. And so unfortunately, there's a lot of services that are limited only to families who are eligible for Medicaid. Black mothers with a college degree are still so much more likely to die in childbirth than their white counterparts. Our Blackness is sometimes the only commonality that decreases a mother's chance at a healthy pregnancy and delivery. From personal experience, I'm one of those women who I am college educated, not using Medicaid, no underlying medical issues. I actually have worked in the field of maternal child health for, years. And, I had a 26-weeker, was not listened to during that period. And then also in my postpartum period was one of those women with a near miss with something Dr. Weber talked about earlier with that delayed postpartum hemorrhaging. And again, just not being heard even after reaching out and saying, hey, there's something wrong, being dismissed, like this is your first pregnancy, everything's fine. And so I think it's really important that those services are available to all Black women, not just those who may be making a little less at the time or may need to use Medicaid at that time. And then finally, as you have heard mentioned at the last panel, the Black Birthing Center, which will allow for us to have a structural intervention to racism, to eliminate biases in care that are connected to race and ethnicity, where everyone in the birthing center will be Black, from the receptionist to the social workers, psychologists, having all services in one spot, really looking at just changing the game as far as that goes.
Thank you so much, Jacqueline. So I'm hearing like a for us, by us type of model with this birthing center that you have, and really how representation truly matters. Thank
Absolutely.
you for sharing some of your story as well, and being personal. And those stories that we heard earlier about the data and then the stories behind the data, they do really help to drive some of the legislative initiatives that we see. So thank you.
You're welcome.
So now I'm coming up on question 2 for all of you, and we have about 22 minutes to continue to move forward. And thank you for such engaging information so far. I'm going to go back to you, Assemblyman Harry Bronson, with this question. And actually, it's going to be the same question for you, Senator Sandra Brooke. So the question I have for the both of you are, what are potential funding sources for innovation in Black maternal health? Really looking at sort of besides governmental, where is the money going to come from to fund these birthing centers and other models of advanced care? And then, you know what, Jacqueline, I'm going to bring you in on this too. So feel free to address, where's the money coming from? How do we make sure we have the resources financially to support this so that they don't just stop after 2 years? We'll start with you, Assemblyman Harry Bronson. You're muted. And
I knew I would do that. I'm now unmuted.
Okay. Yes.
Am I back?
You are. You're back and you're all set.
Great. Thank you. Well, first, let's start with 2, I think, really powerful funding streams that exist. The first has been around for a while, and that's the Safe Motherhood Initiative. And it ties right into some of the physical and medical health issues that are at higher levels of birthing women of color. And in that, it requires the development and implementation of standard approaches for handling emergencies associated with maternal mortality and morbidity, and in particular, focusing on the 4 leading causes, right? Maternal sepsis, the hemorrhaging that one of the doctors talked about a lot in the last panel, blood clots, and hypertension, right? And all of those issues impact people of color at a higher degree. I think it was Dr. Tracy Weber that highlighted much of this in the earlier fund initiative. Am I back?
You are. You're going in and out just a little bit, but you were back.
All right, great. Yeah, the Assembly internet is not the greatest. The second is the statewide birth equity improvement project. This was just put in last year's budget for the very first time, and it's a project sponsored and promoted by the New York State Perinatal Quality Collaborative, and it supports birthing hospitals in their adoption of anti-racist policies and practices at the facility level, with the overarching goal of improving the experience of care and outcomes for Black birthing people. Up through the budget. And
it went out again just a little bit. Assemblyman Bronson, do you want to go off video? I know it's probably an idea, but just to try to save. Okay.
All right. So did you all hear about the statewide birth equity improvement project? You there?
Dr. Connors, you're muted.
Yes, I'm sorry. Yes, we did hear about that. Thank you.
Okay. So so those are 2 state funding programs that we've got to continue to fund in the upcoming budget, and also increase the funding levels in the upcoming budget. As for outside of governmental funding, I think it's important for us to work with foundations across the state, work with and think about the parameters of what you're asking the funding for. So we're talking about birthing individuals of color, but are there ways to seek mental health funding that will be a part of this? Are there funding streams that deal with some of the underlying medical conditions that we're looking at, hypertension and things of that nature? So be creative when you're looking at grants on what their parameters are, and to see if not to adjust your approach of your program, but to see if you can get your program to fit within more expansive parameters would be my suggestion.
Thank you very much for that. Appreciate hearing about some of this funding, again, outside of governmental, and as well as the Safe Motherhood initiatives, really looking at those 4 emergencies that you highlighted, but was also highlighted earlier by Dr. Weber. Jacqueline, I'm going to ask you the second question until Senator Brooke returns. So for you, where is the money coming from to be able to do the awesome things that you are doing in our community?
So Healthy Baby Network, we have been lucky enough to receive funding from Greater Rochester Health Foundation for a number of years to fund some of our services, such as the Black Doula Collaborative, community health work, fatherhood initiative. We receive funding from the New York State Department of Health for some of our community health worker services, Cabrini Health, and then FLIPS for our now community-based doula program, which is what we had our second training in today, training a new group of Black women who will be trained as doulas and be working more closely with the hospital systems. But other than that, a lot of our time is spent writing grants for nonprofit organizations. There's not too many funding resources, so we kind of go out and get them. Just lucky enough to have funding from those places who have allowed us to do what we've been doing for families in the community.
Thank you, Jacqueline. I agree. As president of Rochester Black Nurses, we have also received funding from organizations like Greater Rochester Health Foundation. You know, without them in our community, it would be very impossible to do the work that we're doing. So thank you for identifying them, and then also that you have identified. And then Senator Brooke, same question for you. So what are other maybe possible potential funding sources for innovation in Black maternal health?
Yeah, this is such an important question because all the ideas in the world can't come to fruition without financial support. So I have to say, you know, we've done a lot of work with the doula community here, specifically in the Rochester area and statewide, thinking about how, if at all, legislation might help that community get to the people who need the services. And, you know, it strikes me when we hear so many of the incredible providers and doulas that we have just heard from on this panel and previous panel, discuss giving free services to people who need them. That is admirable and it's noble and it's needed, but let's remember that these are largely women of color and Black women offering their services that should be paid for free. So one of the things that we have been studying heavily, and I would say we introduced a bill yet, but to be honest, you really got to do your homework on this stuff. So we're taking the months that we need to make sure that this is something that is actually going to help people before introducing it. But frankly, we need to look at things like Black maternal health, Black maternal mental health, doula services. We need to ensure that we're looking at these as the life-saving services that they are, right? No one's questioning that insurance is going to pay for an OBGYN to catch your baby at a hospital. No one's questioning that because that's a clear need of services. Well, how is it that when I am a Black woman, I'm a Black birthing person, and I know that securing doula services is one of my most effective ways to make sure that I have a successful, healthy outcome for me and my baby? Why isn't that covered? Why does that have to be coming out of my pocket, which I am happy to pay? I can afford it and I am lucky, but why do only I get that, right? Why does someone who doesn't make that same amount of money or who makes minimum wage can't do that? So I think one of the ways that government can lead is finding ways for things like Medicaid to pay for these things. And oftentimes when you're able to lead in that way, private insurers will follow suit, because a lot of times they don't cover things that aren't mandated to get covered because they're profit-making institutions. So, you know, that is one thing that we will have to move very carefully and deliberately with our doula community to find a way for them to get sustainable funding. I come from philanthropy. I've worked in nonprofits most of my life. I'm grateful to the foundations and a lot of nonprofit partners that have stepped up to fund these things. But at the end of the day, I really think that we need a state government and a healthcare system that says, I don't care if you make $4 or $4 million, you deserve to have the best care possible. And I think that that's what we do when we finally start covering some of these services. So that is one way. You know, I agree with everything that the two panelists said, but to be additive as opposed to repetitive, I would add that as another option and something specifically that we can look into. The second thing I just want to add, in all of the research we've done around these bills, it's really encouraging to see and read that one of the top suggestions or recommendations to solving this issue of maternal and infant mortality and morbidity is to invest in Black women-led community organizations. So when we hear about our Black Birthing Center, when we look at these providers, it is not rocket science. If we have dollars to invest, we need to look at the most grassroots, community-led, Black-led organizations. I think Jacqueline did a beautiful job of describing the importance of that, this for us, by us, right? And in every state budget, we have opportunities to funnel funding towards nonprofits like that. And so we have tried to prioritize that as an office. And I know a lot of my colleagues have too. And that's another thing that we can't stress enough as to where the funding needs to go.
Thank you so much for again, all that detailed information. Sustainability was definitely key that I hear in there because, again, we get these grants, we get the funding source, it's for maybe 2 years or 3 years, and then you have to reapply and things like that. So sustainability, but what about the hospitals? You all have mentioned hospitals in some way, but shouldn't they be responsible? The hospital systems help be responsible for paying for like the birthing centers and things like that, as usually the patients who are there who are receiving the health outcomes that are worse? Anyone can reply to that.
Well, I might just add, maybe as a point of clarification, Dr. Conyers, when we think about alternatives to hospital settings, I think that's something that a lot of people look at, like, things like birthing centers to do this work outside of a medical or hospital setting, and to prefer midwives or to prefer a doula be with you. So I don't necessarily see them as the hospital system kind of scooping up these alternative methods. Rather, what I'm focused on, and I guess I would venture to say others potentially should be focused on, is creating parity between the services and sustainable supports that we give our healthcare and hospital systems, and make sure that's the same as anyone who seeks alternatives. And, not to beat a drum or to go back to some of the things that obviously I'm championing, like my work groups, but the truth is, some of the point of having these study bills, we call them, where we really allow, the Office of Mental Hygiene or the Department of Health to study these things, is then we get this body of work to prove that the existing system has not served equally to a number of people, specifically people of color and Black people, right? And with that body of proof that we have, that's how we fight to say, this is why not only do we need to change the hospital system that we currently have, but you have to allow and pay for, government or insurance, right, alternative systems that will increase and improve outcomes. So that's how I would see it. And that's why I'm so invested in making sure that we have that body of work. So frankly, when I march to Albany asking for money, and y'all are all going to be behind me, right, making sure that we get this, that we have our proof, right? More than a couple stories, we have data and, people's lives, their stories to share, to show, this is why we're asking for this, because we aren't being served right now. And so that's where I would like to focus on that piece by opening it up to my fellow panelists as well.
Thank you. The data is so important. Jacqueline, I saw you come off from mute.
So I think when I think about hospital systems, I think about the big piece, and the important part is to be welcomed into the hospital system as doulas, but as not employees of the hospital system, because our focus is on the moms that we're working with but to still be accepted as part of that team. And I think once that happens, then what will be realized and seen is the positive impact that we have. And then if you're thinking about the pathway maybe to Medicaid reimbursement, and then the future of, doulas being embedded as part of the team, not necessarily having to be a member of the hospital. And so that's what I think about when I think about funding from the hospitals. The way that they can help us be successful is really, welcoming us and, just us working together.
Yeah, collaboration was a word used earlier by Dr. Kyler, and I think it applies here when we're talking about looking at advocacy and legislation. And Assemblyman Harry Bronson, did you want to reply to that at all?
I'm missing a lot of it. Unfortunately, my internet is not working well at all. But if I may, one of the other aspects, and I think I heard Jackie mention the Medicaid trend factors and that reimbursement. We've got to make sure that we're effectively reimbursing hospitals. So that's a funding piece. But beyond that, we also have to have more people of color involved in the treatment. And to get there, there should be incentives like educational loan forgiveness programs for people who are entering into the healthcare and want to practice in underserved areas. There should be financial incentives for people to provide care in underserved communities. But also we need, I believe, a dedicated funding program for the development and implementation of statewide training.
Assemblyman Bronson, you're cutting.
Having more. Okay.
You mentioned dedicated training, and then it got a little fuzzy. So if you want to wrap up that.
Okay, and that would be statewide training for providers on implicit racial bias.
Yeah.
So a piece of it is having more people of color involved in being providers, but the other piece is to make sure that we have a comprehensive approach to make sure we have a culturally responsive evidence based, but
Thank you. And what I'm hearing, and I'll try to repeat this, is so again, looking at two things, looking at having, again, for us bias model, but also discussing implicit bias with healthcare providers, as has been discussed earlier with even on our first part of the panel when Dr. Weber said implicit bias is something that, you know, is her one word that sort of comes to mind. So thank you for that. And I'm just going to give you guys 30 seconds, maybe. I know it takes a little bit longer than this, but, you know, in these discussions, how and when is the voice of the Black mother, specifically in this case, involved? How is that being included?
So I'll take that. I think one way is that the Black mom's voice is heard when we work with her to create her birth plan. So this is the way the mom is able to think about what she wants and what she wants her experience to be, not what somebody else wants her experience to be. And so maybe a mom we work with might want to listen to soft music or have the lights dimmed, maybe while sitting on her birthing ball. Another mom might want to play cards with her husband that might make her feel calm and relaxed during labor. And so that's so important, discussing whether or not they want to use pain medication, educating what it is beforehand so they're able to use their own voice. I think another way is by listening sessions, really hearing what the mom's experience was, and after that, taking that feedback to improve upon the programs we already have and add new ones, looking at surveys or kind of different than a satisfaction survey that you might have in the hospital, but, you know, an experience type survey from moms after they receive program services from a doula. And then also Healthy Baby Network has a community action network where members from community organizations and then parents are able to come together and look at what's going on in the community. How can we improve upon lots of different things, housing services, but also maternal and child health.
All those other social determinants, right, that we know are affecting our Black birthing persons. So Senator Brooke, same for you. So in your creating of different bills and wanting to get things passed, how is the voice of the birthing person being included?
Well, I'll tell you one piece, this Black birthing person is always a part of that conversation. And that is, I mean, I'm making light of it, but also let's be very real, that has never happened for our area before, to have someone with my lived experience sitting in the room making these decisions. And the beauty about having folks like that in the room is not only am I bringing my own lived experience of being, you know, of using these screening tools, of going through the healthcare system, right? But innately, I know that I don't carry everyone's experience with me. And so to be honest with you, it is incumbent on us as elected leaders to ensure that you all are at that table with us, to ensure that we have created connectivity with you where we are accessible to you, you are accessible to us as we move through the legislative or budget process. So one thing I'm very proud in my 13 months so far as a state senator is the bulk of my time has been spent reaching out, which is why I know everyone on these panels, because we have been reaching out to the people who are leading these organizations and doing this work and have lived these experiences. And that's also why we are trying to be so deliberate with how we move forward with a bill or a budget ask to ensure that it will have the intent really isn't enough. We need to make sure it has the impact on our communities, because quite frankly, let's be very clear, and this will be my last 30 seconds, I promise. I first learned about the horrific numbers in our country about Black maternal mortality and morbidity almost a decade ago. And our numbers are not getting better. So many ways our country and our state have improved, and these numbers are not getting better. We do not compete with other countries that are as rich as ours or as developed as ours, and that is abhorrent. And so there is a huge urgency behind this issue, and that's why we want to make sure we do it right, and why I put it out there now for anyone who I haven't had the pleasure of speaking to. Please reach out to us if we don't know about your organization, because our bills are only as strong as our relationships with the people doing this work.
Thank you. Assemblyman Bronson, anything from you?
Yeah, absolutely. What the senator just said, I think highlights our need to follow the lead of ABC and many others who have recognized, articulated, and demanded that we see racism as a public health crisis. We have to move forward in a way that we look at our health through the lens of racial justice. And that movement, I think, is going to make all the difference as we go forward. And a key component of looking at racism as a health crisis is to listen to people of color. And
Sure.
we have to create venues to hear from them, and we have to be willing to listen and be open to the ideas, the perceptions, what they have gone through, so that people who look like me can better understand what's happening there in the field.
Thank you very much. I appreciate you all for taking time on this panel with me today. Just a reminder, I'm going to get ready to pass it back over to Jerome Underwood, but there's going to be a poll with only 3 short questions, so please just take some time to answer those. And Jerome Underwood, back to you. And thank you all again, panelists. It's been my pleasure and honor.
Thank you, Dr. Conyers, and thank you to all the panelists in the part 1 panel and part 2 panel in this really important topic with respect to maternal health and mental health added into that. These are extremely difficult issues that we have to face with, but we must face them. And there's never enough time, because as the panelists so eloquently said, the action is what we want to get to so that we can close these gaps with disparities. So thank you. I see you filling out the poll. Thank you very much. The data is important, but as Sharita Bullock said, we got to take that data. Lived experience is data. And so knowing people's stories,